So in this video, we'll discuss the endoscopic ear surgery. This is very hot topic in exams also. It comes frequently in MS and DNV exams. They give 10 marker on comparing the endoscopic and microscopic technique for ear surgery. So we'll discuss coming to the introduction of the endoscopic ear surgery. Introduction of the operating microscope to ear surgery by Woolstein was a transformation event in the development of the ear surgery. Increased ability to visualize disease process and associated anatomy has resulted in a more effective surgery with reduced complications and increased ability to perform reconstructive procedures. In last 3 decades, many surgical disciplines have adopted endoscope as an instrument of choice to access and correct pathology without undue disruption of the overlying tissue. Incorporation of the endoscope into the surgical technique in otology has contributed greatly to the concept of minimal invasive surgery. So, coming to the debate of microscope over endoscope in 1950s and 60s. In 1950s and 60s, operating microscope was introduced in the otologic surgery because of excellent illumination, depth perception, and magnification, binocular vision, ability to work with two hands, capacity to capture SD images and videos, and thereby leading to the research and development and teaching. Despite all these advantages, it also has certain limitations. So let's discuss the microscope versus endoscope field of view. You can see that this is a field of view with microscope, this is with microscope, and this is endoscope. You can see the difference actually. So this is limited microscope field of view due to narrow segment of the ear canal, and this is wide endoscopic field of view. This is limited transcanal microscope access. This is wide post-auricular access. So the view from the microscope during transcanal surgery is defined as limited by the narrow segment of the ear canal. In contrast, the endoscope bypasses the narrow segment and provide a wider view that allows the surgeon to look around even when 0-degree endoscope is used. This is very important. So coming to this, the limited view provided by the microscope during transcanal procedures has forced the surgeon to perform post-auricular mastectomy, in which a port parallel to the aortic is created after a considerable amount of healthy bone has been removed to enable the anterior keyhole surgery access to the attic. So this is microscope endoscope views of the right ear operating microscope full zoom 6 mm oral speculum region, right ear 0-degree endoscope. So coming to the type of endoscope. So rigid endoscope, Hopkins rod lens system, we use diameter R 2.7. 2.7 is commonly used in the ear. That is pediatric endoscope, we say, or auto endoscope. 2.7, 3 or 4 mm. 4 mm is the normal conventional one. Working length 18 centimeter, 15 centimeter, 14 centimeter, 11 centimeter, 6 centimeter. Angle 0-degree, 30-degree, 45 degrees, 70 degree. There are also flexible endoscope. So you all can see the photograph. This is 0-degree, this is 30-degree, this is 70-degree. This is the flexible video scope equipped with digital sensor with video chips, the tip of the instrument. Okay. So this is very important slide. I will like to draw your attention to this. This is central axis of the, this is 0-degree, Hopkins rod system, 0-degree. Central axis of the field of view and axis of the scope. This is 0-degree direction of view. This is field of view. Field of view is this yellow part, and this is direction of view. And this is called axis of the scope, the line. And this is central axis of field of view, like so, 0-degree. So diagram showing the field of vision of each type of endoscope. Each type of endoscope. This demonstrates the need for modified angle instrument to be able to look around the corners. Field decay, direction of view. What is direction of view? This is Arjuna Viva. What is direction of view? The angle between the mechanical axis and center of the field. Angle between the mechanical axis and center of field. In this is angle between the this center. So the angle between the mechanical axis and the center of field of the view. Field of view, what is field of view? The angle measured at the tip of the endoscope to 2 points at the extreme diameter of the viewed field. Depth of the field, the distance between the object placed and close to the possible to the distal field of the endoscope while remaining in focus. That is near object. And an object placed as far as possible from the distal tip, the remaining. So देखिए जो हम 0-degree 30-degree किस पे बोलते हैं? Central axis of the endoscope या mechanical axis of the endoscope and the axis of the field of view उसके बीच. So Hidden structures we can see through endoscope. So schematic drawing of the sinus, tympani, and pyramid area showing the field of view of endoscope for different sinus. The position of retrotympanum. The position of retrotympanum. Complex with respect to tympanic axis. The red shows the arrow shows where the retrotympanum is located. Malleus. So these are you can see that uh, this is trapeze, round window, promontory, stretching tube. This endoscopic view of the middle space are retroradial. The cerebellum is a ridge of bone arising from the stellate complex to the posterior field of okay, endoscope have many proven advantage over the microscope. Wider angle of view, better visualization of structures that are parallel to the axis of the microscope. Visualization of deep recesses and hidden structures. So wider angle of view है. First is this. Then better visualization of structures that are parallel to the axis of the microscope. Visualization of the deep spaces and hidden structures. That is round corners. The ability to visualize beyond the shaft of the surgical instrument. Preservation as much normal anatomy as possible by minimizing unnecessary dissections of bone and soft tissue. So component of endoscope, you all know that this is light source, this is monitor, this is endoscope, this is camera or setup this. So how operating room is planned in endoscope, so this is very important. Diagram of the operating room setup and the patient position. You can see that surgeon is sitting here, microscope has been put from behind, and in the front this is the monitor, assistant is sitting here. So indication of endoscopic ear surgery. When we do external endoscopic ear surgery, for the so indications from the external ear pathology are canaloplasty, uh, debridement and biopsy, external auditory canal cholecystoma, middle ear. What are the procedures in the middle ear which we can do through endoscope? Myringotomy, tympanoplasty, ossiculoplasty, glomus, cholecystoma, stapedectomy. So inner ear skull base, what we can do through endoscope. So intracochlear schwannoma, small symptomatic neoplasm of the IAC fundus or facial nerve, petrosuffix, cyst, perilimb fistula repair. Middle cranial fossa, superior semicircular canal dehiscence repair. Posterior canal fossa, identification of residual schwannoma in IAC. So determinants of the surgical procedure. There are three primary determinants of surgical intervention: size and orientation of the ear canal. So while planning the patient for the endoscopic ear surgery, we have to take into consideration these things: size and orientation of the ear canal, site of the primary obstructions, cholesteatoma within the size and orientation of the ear canal. This always we see site of primary obstructive process, cholesteatoma within the mastoid cavity proper. Endoscopic myringoplasty. Although in general microscopic myringoplasty is considered as a safe operation in the endoscope technique is probably even safer due to the absence of an external incision, which minimizes the risk of post-operative wound infections or hematoma formation. Advantage of endoscopic myringoplasty: the tortuous EAC with the endoscope approach, it is only rarely necessary to widen the canal. Direct visualization of the entire eardrum. Direct visualization of the entire eardrum. Direct visualization of the tympanic cavity and related structures such as ossicular chain, chorda tympani, seventh cranial, and the round and oval window. Clear visualization of the anterior annulus and anterior limit of the eardrum perforations. Endoscope evaluations of the middle ear ventilation routes during surgery. Absence of wide external incisions and dissections of the periauricular tissues. So disadvantage. What is the disadvantage of uh, this endoscopic myringoplasty? The technique is more difficult than the traditional one, especially in the hands of inexperienced surgeons. So remember this: one-handed technique. One-handed technique. It is impossible to employ an overlay technique in relation to the fibrous layer of the tympanic membrane. Indications and contraindications. So, what are the indications of endoscopic tympanoplasty? Age of the patient not less than 6 years. Immaturity of the EAC and its limited dimensions due to as immaturity of the EAC and limited. So don't do endoscopic tympanoplasty for the age less than 6 years. Middle ear and perforation appearance: dry marginal perforation involving an elbow. Tubaric function, stretch and tube. फिर देखिए endoscopic transcanal techniques can be performed in two ways. Meringoplasty through the creation of the tympanomeatal flap, then meringoplasty without creating a tympanomeatal flap. Meringoplasty with fat, butterfly meringoplasty with cartilage. So this you can see the program nicely. So margin perforation is being done. Then an incision of the external auditory canal is made with a circle using the so you all say this, see this. So the dissection of the eardrum from the handle of the malleus is performed carefully, detaching the eardrum from the posterior malleus. So without tympanomeatal fat, two procedures can be distinguished. Fat meringoplasty characterized by the removal of the abdominal or auricular fat. Two procedure without tympanomeatal fat, without tympanomeatal fat, we can do two procedure. Fat meringoplasty characterized by removal of abdominal auricular fat, or butterfly technique meringoplasty characterized by a cartilage model in a spoon or bobbin shape. Fat grafting. This is fat butterfly shape. So endoscopic cholesteatoma surgery. Now we'll discuss the endoscopic cholesteatoma surgery. These are three basic approaches to the endoscopic management of the cholesteatoma, which echo the principle of the lesions learned from the traditional tympanomastoid surgical procedure, which is done at the microscope. Transcanal management of the limited cholesteatoma, open endoscopic management of the cholesteatoma, and extended transcanal approach of the cholesteatoma. Transcanal exclusive endoscopic approach surgery. So transcanal exclusively endoscopic approach surgery. Indications: primary or secondary acquired cholesteatoma involving the tympanic cavity, mesotympanum and epitympanum regions with no antral mastoid cell involvement. Attic cholesteatoma with no antral mastoid cell involvement. Retrotympanic cholesteatoma with retrotympanic cholesteatoma or hypotympanic cholesteatoma, no antral mastoid cell involvement. Selective and progressive eardrum attic retractions. Selective past tensor retractions. Congenital cholesteatoma involving the attic or mesotympanic compartment with no antral mastoid cell involvement. So, what are the contraindications? Contraindications of this cholesteatoma surgery: transcanal exclusive endoscope approach surgery. Contraindication: mastoid cholesteatoma, lateral semicircular canal fistula, dehiscence of fistula of the dura mater, small external auditory canal. So this we can see that this shows the a possible indication for endoscopic ear surgery on the basis of the location of pathology. Areas that represent the extension of the disease in the tympanic cavity. So A is limited attic disease, B is no mastoid involvement but tympanic cavity is involved, C is attic cholesteatoma with extension to the antrum perianthus, D is these contraindications, that is cholesteatoma involving the mastoid. So coming to the combined approach, endoscope microscope combined approach. When surgery is begin as a transcanal endoscopic approach to the tympanic cavity to remove the pathology from the tympanic cavity of the mastoid antrum, and continues with a microscope mastectomy in order to reach and remove the pathology in the antrum and mastoid cells. Then coming to the microscope endoscope assisted approach, when classical microscopic surgery is performed with canal up or canal wall down technique, and after the microscope surgery the endoscope is introduced into the cavity in order to find and remove the residual disease with canal up technique with canal down. Advantages of combined approach. We will discuss the what are the advantages of combined approach. So better control of the disease in the tympanic cavity by the use of endoscope and the possibility of maintaining the integrity of the posterior wall of external auditory canal. Easier study and better understanding of the pathophysiological mechanism underlying the cholesteatoma. Preservation of antral and periantral mucosa when possible, so as to maintain the proper homeostasis of the middle ear in the postoperative period. So disadvantages of endoscopic ear surgery: size, one-handed surgery, limited instrumentation. Safety concern: excessive heat dissipation. This is one very important concern. Trauma from the tip of the endoscope, safe distance of uh, less than 5 mm from the inner ear structures. So these are my selected references. Hope you have enjoyed this video. For more such video, subscribe to my channel.